Bismillahirrahmanirrahim. So after atrial fibrillation, the next topic is atrial flutter. So let's talk about atrial flutter today. Alright, so what happens in this case, we'll have a circuit that is present in right atria. So let me draw here. So this is superior vena cava and this is inferior vena cava. Then we'll have this valve that is called as tricuspid valve, right? And then we'll have this RV, right ventricle. So basically we'll have a circuit here between inferior vena cava and tricuspid isthmus, right? So this is called as the macro reentrant circus, right? That is present in cavo-tricuspid isthmus, right? So in atrial flutter, basically we'll have this circuit that is called as the macro reentrant circuit, right, in cavo-tricuspid isthmus, right? So this is responsible for the sawtooth appearance in the ECG, right? So basically in atrial flutter, what happens, the right atrium basically is going to operate on this circuit that is macro reentrant circuit, right? So we'll get the multiple PVs, right? So multiple PVs, and then we'll have this QRS complex, and some PVs are blocked here. So when we see, if we see the 3 PVs, right, so it means it is 4 into 1 conduction, right? So basically AV node is blocking one of that, and right. So let's talk about this thing. So in atrial flutter, we're gonna get the macro reentrant circuit in right atria that fires at approximately 240 to 350 beats per minute, right? So it is present in cavo-tricuspid isthmus, right? So we'll get the sawtooth appearance in leads 2, 3 and AVF, because 2, 3 AVF are reading the right side of the heart. So we'll get the these sawtooth appearance in inferior leads mostly, right? So as circuit is present in right side of the heart, so it will be in right in the inferior leads, right? So in if we talk about multifocal atrial tachycardia, right, so in that condition we'll have the ectopic foci, right? So there will be ectopic foci that will be present in right atria, right, in the right atria, right? And if we talk about atrial fibrillation, so mostly we'll have the ectopic foci which are present in the left atria, right? So there's a difference between these two. And also if we talk about atrial flutter, so we see this circuit is present in the right atria, right? Okay, so there was a bit difference between that. So what we need to do, we have to just first control the rate in this patient with the esmolol or verapamil, right? So we'll have to do the rate control just like that of atrial fibrillation. We'll have to give the beta blocker or calcium channel blocker for rate control. And then so we'll have this race protocol basically here. So O stands for rate control. Then we'll have to anticoagulate this patient, right? Because of multiple twitching of the right atria, there will be stresses of blood, so we'll have to anticoagulate this patient. So then we'll have to go for the chemical cardioverine or electrical cardioverine, right? So then we'll have to anticoagulate, because there is risk of pulmonary embolism, because it originates when there's stasis of blood in right atria. So they're gonna go into the right ventricle and then they're gonna go into the pulmonary circulation. That's how they're gonna form the pulmonary embolism, right? So we can give the now warfarin is not that much used, right, because of its high risk of intracranial hemorrhage, and we have to go for the repeated labs again, like we have to check the PTA INR, right? So with NOAC there is no such labs needed, right? So also warfarin has some the interaction with the food, and also it has interaction with some drugs. So that's why we mostly use the novel oral anticoagulants or direct oral anticoagulants these days, right? So To control the for the chemical cardioverine, we can go for the abutolite, right? We can use the injection abutolite 100 to 200 mg. Then if it is not available, we can go for the amiodarone, right? So that's the approach to the atrial flutter. So if it is refractory to the chemical cardioverine, we can go for the DC cardioverine, right? So we can give the lowest possible dose of um, electrical shock, that is 25 to 50 joules in these patients, while we usually give the 200 joules in atrial fibrillation patients, 150 to 200 joules. But in atrial flutter, we'll have to give the low energy shock to this patient, right? So we will see the sawtooth appearance in atrial flutter, but if we see sawtooth appearance in EEG, so that is seen with REM sleep, right? And if we see delta wave like that in Wolff-Parkinson-White syndrome, if we see delta wave in ECG, that is Wolff-Parkinson-White syndrome. But if we see delta wave in EEG, so that is seen in non-REM and REM stage 3, right? So that's a big difference between these two. So atrial flutter and atrial fibrillation, is the management is bit same. In atrial fibrillation, we'll have the risk of systemic emboli, right? So we'll have to anticoagulate this patient. But in atrial flutter, there is risk of pulmonary embolism, so we'll have to anticoagulate this patient with novel oral anticoagulants, right? If patient is present within the hospital territory, so we can anticoagulate this patient with that of Clexane or heparin, right? So that's all for atrial flutter. So I'm going to discuss about the ventricular tachycardia in next video. That's all for today.